Right. Good evening, everyone. Welcome back to the OSCE Community Medicine class held by ERPM Mastery. I'm sorry, last time we had to cut our session short, so I'll make up for it today by doing some extra stations. Can everybody hear me?
Yes, sir.
Okay, so we'll start off. So there are some few new names who were there last time. So I will just give the brief introduction I gave last time as well. So for your new format, for your new ERPM exam format, you will be having OSCEs, right? So this is the only guideline we have currently, which is describing these OSCEs. We don't have anything else, and in those guidelines, you have this section which describes what this is, right? So there's a ERPM Part 2 exam. So there it will be an OSCE, which stands for Objective Structured Examination. So these OSCEs are different from what you had earlier. So when you had cases, that was a little bit unstructured, right? You were given a case and you were told to take the history and examination, and you were given a time, and then you were taken back and they asked questions from you. So there was some sort of a subjectiveness, and there you had some freedom. Here, of course, OSCEs, they are very objective and they are very focused. So they are each station will be only for 10 minutes, and you will have overall 20 stations. Out of that, 18, as mentioned here in your new guideline, will be the actual test stations. The others will be rest stations, the other two. And here you will find, now when you're doing the OSCE, you will find two problems coming up. One is that this is going on for over 3 hours, right? If you remove the 20 minutes for the rest station, even then you will have 3 hours of continuous questions and procedures and examination and stuff like that, right? So you will have to prepare yourself mentally and physically for this thing, right? The other thing is, different from your usual format. When you are going for this, you need to prepare for all of these subjects, right? And when you are going into the station, we don't know exactly how the station will be structured. But when you are entering, sometimes you might not know what subject this is, because it's clearly mentioned here. Although these are the subjects and these are the number of questions from each of these subjects, the actual questions that you will face can be mixed content. So you can have a mix of content within the same station. So in the same station, you might have gyn and obs part and a community medicine part, or you can have a forensic, a medicine part and a psychiatry part, right? So exactly how this will be structured, we are not sure. There might be some guidelines coming out which will explain how this will be brought, carried out exactly. So until then, we expect that this will be sort of structured along the lines of either PLABO, USLME, and exams like that, how they carry out those keys. So here you will need to answer in a very exact way, because they will have a marking sheet. So the marking sheet will be having exact specific criteria for them to give you marks. So you will need to hit those criteria for them to be able to give those marks to you. So what we expect in this is, we will see how if they release any guidelines, we can know the exact way they will do this. But for now, what we expect is they will have stations, and in those stations, most likely you will have some sort of a scenario written in front, right? And they will give you a little bit of time to read that scenario, and then you will have to go into the station, and that's when your 10 minutes will start, right? So that is most likely the format that you will have. And there, what you are going to expect is that within that station you will have different kinds of stations, right? You will have history taking stations where you have to take a history. There might be examination stations where you have to examine a patient under the observation of an examiner. So they will be observing whether you do it correctly. And there might be stations where you are expected to interpret certain reports, certain data, certain charts, or in a clinical sense, ECGs, X-rays, stuff like that. And there might be stations which evaluate your skills, right? How you insert a speculum, or how you do certain procedures, how you do a vaginal examination, how you do abdominal examination, stuff like that. And then there will be counseling and education stations, so where you have to interact either with an actual patient or with an actor, a role player, right, where you have to counsel that person. So that might also be there. And there might be straightforward viva sort of questions where they will sit you down and ask you structured questions. And there might be combinations of these as well. So you might have a part A, which is history taking, and then you might have a counseling session for that patient. So there might be combinations of these as well. So you need to be ready for those sort of stations, right? Right. So that is what we discussed earlier. So now we'll go on to the actual, questions. So in the community medicine questions as well, what I expect is that there will most likely be mixed stations where you will have the first part that will be given, either pediatrics, gyn and obs, medicine, and then the second part they will go into the community medicine part. So you can have an infectious disease and they will ask the clinical stuff in the first part, then they will go into the public health part or the community medicine part in the second question. So stuff like that might happen. So we'll try to cover all those mixed parts as well as complete community medicine stations. We'll try to get a overall idea of what you can expect in these. So the thing with OSCE is I'm going to need some your participation as well. Otherwise, it will be a little bit difficult for me to explain these things. And the other important thing is, obviously, these are not things that you can just sit down, learn, and go and do. Right? You need to practice these things. So make this an opportunity. So use this opportunity to actually practice with what you have. It's okay that you fail now. You might not be able to do your best now. That's fine. If you learn now, if you learn at this moment, you will be able to retain it at your exam. So you will know what to expect at your exam. So please volunteer for these stations. There will be role playing stations as well, right? So for the first station, this is going to be a scenario, right? Give me a moment. So we'll actually give me a moment. Right, sorry. Right. So this is the scenario. You are the MOH at a family planning clinic. A 38-year-old woman, Mrs. Shanika, has come for family planning advice. So your task is to take a brief relevant history and counsel her regarding her contraceptive options, right? So this is something that's you're going to face as an MOH, as a HO in the wards, at the HO when you're doing the clinic. So you will have patients coming who will be coming for family planning advice, who are asking you what sort of family planning method they can take. So do I have any volunteers for this? So I will time you as well. So we'll try to make this a 10-minute thing. So you can do your best, and don't worry if you can't come out here with everything. You will be able to remember this until your exam, right? So can I have a volunteer?
I can.
All right, Nipune, good. Okay, just imagine I am the 38-year-old woman coming for family planning advice. So you are now, you have to take a history from me. So I will be role playing the patient. Okay, so you can start, and I will time you as well for 10 minutes, right? So go ahead.
Good evening, Mrs. Pereira. I just want to confirm that your name and age, please.
Yeah. My name is Shanika Pereira, and I'm 38 years old.
Are you comfortable carrying this conversation in English or Sinhala?
I'm comfortable in English, doctor.
Okay. All right. So I am Dr. Nipuni. I am the MOH here at this clinic, and I understand that you're here to speak about contraception.
Yes.
Okay. So can I please know? So do I start with like the normal history taking format?
Yes. So you can it's up to you, right? If you can start however you want. You can ask me a question, or you can ask my ideas. We'll see at the end as well. We have a marking scheme, but just go ahead with what you're comfortable.
Okay. So are you married?
Yes, I'm married.
And what do you do for work?
I am a development officer at the local AG office.
Okay. And what about children?
I have 3 children.
And what are their ages, if I can ask?
Yeah, my eldest daughter is 6 years old. My second one is 3 years old. And my youngest son is 6 months old.
And how was the delivery? Was it all normal
All
delivery?
three are normal vaginal deliveries.
Were there any complications during the delivery?
No complications, doctor.
Okay. And have you used any contraception in the past?
Yes, I have used. I remember taking hormonal the pills earlier. I have taken for about 1 year previously, but sometimes on and off I got some, sort of bloating and gastritis with those pills.
Okay. And can I know when your last menstrual period was?
So I started about 2 weeks back. I started.
And do you have normal periods? Is it heavy? Is there any pain?
No, my periods are regular, doctor.
They are on how many days interval?
About 1 month,
And how many days do you usually bleed for?
about 3 4 days.
And the passage of blood is also normal. There is no excessive blood.
No,
And what about your, are you sexually active?
yes,
And are you frequently sexually active? There is no problems there.
no issues there, doctor.
And can I know your height and weight?
Okay, my height is around 153 centimeters and my weight is 70 kilograms.
And what about your dietary habits? Are you vegetarian, non-vegetarian?
No preferences, doctor.
Okay. And do you smoke?
No,
Alcohol?
no alcohol.
Okay. Any history of allergies?
No allergies, doctor.
And any surgical history? Past surgeries, anything?
No, doctor.
So, from the brief history that I have taken from you, you are eligible for multiple forms of contraception. So I can present to you which contraception forms are available, and we can get together and decide which one is more suitable for you. So since you have had some adverse effects previously with hormonal therapy, we would not try that again. So we could go for the DMPA, which is a injection that they give. You have to do it every 3 months. And we have also another option of uh, a, a Jadel device, which is a small rod-like implant that you put
Doctor,
under
are
your.
those hormones similar to the pills I took earlier? Will I have the same side effects?
They are hormonal contraception, but since your adverse effect was for the pills, maybe it was a mixed related a pill problem, but it might happen. So if that is the case, we can also go for a copper IUCD, which they would place inside your uterus, and that would give you a contraception for up to 10 years. But it's better you can change it in about 7 if that's the choice. Oh, also, I forgot to ask you, I'm so sorry. How long do you want to have your contraception for?
So I think, doctor, I don't want to have any more babies.
Okay. And is this a decision that you and your husband took together?
Yes, doctor.
Okay. So if that's the case, we can also offer you a surgical procedure, which is known as tying your tubes in normal terms. So it has
Like
a.
surgery, doctor. I am afraid of surgery.
Okay. So then I would suggest you that the copper intrauterine device is most likely the best option for you. So are you okay with that? Do you have any concerns?
Yes, doctor. I have heard when you put it, you get backaches and stomach aches and stuff like that. Will I get those side effects, doctor?
So, like any other contraception, side effects may happen, but it's only in a selected number of people that you see these side effects. And it's usually inserted safely. And most of the time, in majority, there is no side effects like that.
Okay, doctor. So, doctor, do I have to choose now or can I?
No, you don't have to choose now. You can take your time. But if you are going to take some time, I would recommend you to use a barrier method like a condom during sexual intercourse. And once you do decide for sure, we can come back and do the insertion procedure.
Okay, doctor. So, IUCD is the only method that is suitable for me, doctor.
Uh, IUCD, there is hormonal IUCD as well. So they're both devices that you place inside. And since you are not okay with surgery and hormonal contraception has shown some side effects, we have a very limited choice because of that.
Okay, doctor. Okay, doctor. So, I'll talk with my husband and come back and let you know, doctor.
Okay, thank you very much.
Okay, very good, Nipuni. Okay, you did very well. Okay. So you touched on most important things, and yeah, were within time as well, 8.5 minutes. So right, so you touched on the most important stuff. So like the station mentioned, you have to take a brief history and then counsel. Right, in the history taking, you have to ask about the children and the spacing, especially the spacing from the last child. That is very important, right? Because that will decide on your mode of your method, right? There are certain methods you can't use within certain postpartum periods, right? Like for example, you don't give OCPs within the first 6 months of postpartum period, right? So you need to know the spacing, especially with the last child. Then you need to ask about return of menstruation, especially with postpartum mothers, right? They can get menstruation even after 1 month of postpartum period, right? So then you have to ask about that as well. You correctly asked about the LMP and stuff like that. That was also okay. So then you also correctly asked about previous contraceptive use. You should have asked about side effects as well, right? Right. So then early, if there were side effects, you ask generally, but be more specific, right? And what you forgot to ask initially, but you came back and asked, you have to ask about future pregnancies, right? If I have completed my family, I might only need one child, I might only have 3 children, but I might not need future children, right? I might not have a plan to have further children. In that case, your decision is completely different from what you would offer earlier, right? So you need to ask about the future pregnancy intention, right? And then you need to ask about past medical history as well. So you did not ask about that. Why? For certain hormonal methods. So there were, I sort of you know told about the hormonal method side effects and stuff that might have led you away, but you need to ask the past medical history as well. You asked about the past surgical history, but you need to ask about the past medical history as well. Why? Because uncontrolled hypertension, uncontrolled diabetes, all of those are contraindications for the OCP pill. Why? Because they have an increased thrombosis risk with those people, right? And for IU series also, you need to ask specifically. If I decide, you can ask at the beginning when you sort of think I'm going towards IUCD, or after I decide IUCD, then you have to again ask about specifically, do I have any contraindications for that? Do I have any history of PID, fibroids, or maybe uterine surgeries, bleeding disorders, right? You need to ask specifically about that as well. And you need to sort of give the choice to me. So that is called the cafeteria method. So you can't just say this is the method use, right? So in contraceptive counseling, you have to give the client options, at least 2 or 3. So there will always be 2 or 3 options that will be beneficial to that client. So in my case, what did I want? What did that patient want? Her pregnant, her family was complete for her. She didn't want any more children, but she was hesitant to go for permanent family planning methods like LRTs. So then you need a long lasting method which wasn't those permanent methods. So the two main options at the very top were either IUCD or what? Other one was implants, right? Either Jadel or implants, 5 years or 3 years, right? So either of those two are fine. So when you are telling about those, just mention those two are the methods. And if you can tell a little bit about each of these methods, that's also good. Pros of this, cons of this. So IUCDs, they last a long time. You don't need to do anything. They will be there for 10 years. The disadvantage is you can tell about the little bit side effects, right? When you put this, some people have a little bit of bleeding, spotting, and abdominal pain. And if they have those concerns, we will see how you address them later onwards as well. And for the implants, so you need to repeat them. If you are going for long duration, you will need to reinsert them every 3 years or 5 years, right? And they are hormonal methods. So if you have certain side effects too, so you might have certain effects to those hormones as well. So if when you are giving IUCD, you need to explain about the IUCD as well. If you decide on IUCD, obviously for this patient, the IUCD was the better method, and you need to clarify certain things about that as well, right? Because this is a 38-year-old mother, right? She will have to replace that. She will be due to replace that when she's around 48 years. Or if she decides earlier she wants to remove, so then you have to explain to her, as soon as you remove the IUCD, your fertility will return. So that message has to, go through to her. Right. And if you are breastfeeding, so you need to explain that IUCD is safe in breastfeeding as well. Right. And the communication. So these are the general domains that you need to focus on. And then, Nipuni, you also need to a little bit focus on communicating in what? Simple language, right? You ask what is your surgical history and stuff like that, right? So you need to ask specifically, did you have any surgeries done? Did they cut open your stomach or stuff like that? You are need to ask in simple questions. And there is a guide which guides you towards that, how simple language to use. What is that? So in your basic biohistory, you ask your name, your age, your job, and then your also education level you can ask, right? Up to which level of school you have gone, so you can ask. So those will be sort of indicators to sort of gauge how educated they are, so you can tailor your message to those to that population. So then you have to offer them choice. You can't just pressure them into one. You can't just give one option and say this is the best, you have to use this, right? So when you are communicating actually, so this sort of a station, they can very easily have a role player, which means they will choose somebody as a role playing person, and they will get that person to role play, and they will observe you counseling that patient. So you need to also be calm, and you need to you need to make sure you come across confident and in a professional manner, right? And then you need to counsel them on how you insert this as well, the IUCD, how it's put, what is the procedure, and then explain a little bit about the side effects as well, right? Sometimes these role players are given a card on what to ask as well. They will be given this background information, right? And they sometimes, if you don't come out with these things, they will prompt you to, right? So you need, it's better if you before they can prompt, if you can come out and ask them about this, it would be better. That's a better impression of you, right? That shows that you have thought of these things, right? So if you can come out before that, that means you might get a little higher marks for that section, right? Right. And then another thing that you need to also explain, if that patient regardless, you need to explain that they need to be followed up as well, right? So any person getting a family planning method, they need to be followed up. So especially for IUCDs, they are usually gotten back 1 month after insertion to check on the at the MOH clinics. They are gotten back 1 month after insertion, where their vaginal examination is done to check whether the string is there, right? And then they are also taught how to check for those two strings, whether they are there on a regular intervals, like every 6 months or stuff like that, so that they can check themselves whether the string is there, whether it's been dislodged, or the location has changed, right? And also at the end, you also need to give them time for decisions, right? You need to tell, okay, you don't need to come now, you don't need to decide now, you can go home, you can talk with your partner, you can talk with your husband, and come back and tell me. And you correctly said the interval contraception. So until then also you need to tell there's a chance of them getting pregnant, so you need to emphasize to them they need to undergo some sort of interval contraception in that meantime, right? So good, you did a fantastic job. I think that you would have done very well, right? So if you can fix the other things as well. I was just wondering, why did you ask about diet, Nipuni?
It's like standard, so I
Standard.
just went to
Okay,
the
right.
standard history.
Okay. So for focused history, just try to focus, only on the most needed parts, right? So in the long cases and short cases, of course, you can take everything you want. In these focused histories, they will be looking at you, right? Then they will pick up on these, odd things, right? They won't, obviously they won't deduct marks for this, but it's a sort of, they look at you in a sort of different way when you ask something like that, right? So good, you ask about the other complications and stuff like that, and the allergies also. Again, you have to ask very specifically, right? Don't just ask, do you have any allergies, right? You have to ask specific allergies about drugs, foods, plasters, and stuff like that, right? සිංහලෙන් ආන කෑම් වලට මොකද්ද බෙහෙත් වලට ප්ලාස්ටර් වලට මොනවා හරි කසලා පළු දාලා ඇලර්ජික් වෙලා තියෙනවද කියලා, you need to ask that entire thing if it's done in Sinhala, right? In English also, just ask about that, not just allergies. Sometimes they might not know what allergies are, so you need to ask, right? Right. So good, you did very well. So that's the sort of thing that will be expected, and this is the sort of marking scheme that we sort of expect. We are not exactly sure what sort of a marking scheme that they might come up with. They might, like this marking scheme, there's a little bit of room for them to give marks. So if they give, so for this thing they give 4 marks, so within that 4 marks they can deviate from 1 mark to 3 4 marks, they can deviate. Sometimes they might have single mark station criteria as well. If there's one criteria, they will have one tick, and that is 1 mark. So they might have that as well. We are not exactly sure how the marking scheme will be, but what we do know is that it will be structured like this. So you need to hit all these points, you need to give all these points in your history taking or in your counseling session to be able to be eligible to take these points, right? Okay, so let's go on to the next station. Right, station 2. So this is more of a mixed station where you have, like I said, this is a mix of medicine and community medicine, right? So in this scenario, you are working in a medical clinic as an HO. A 58-year-old male is about to start on hemodialysis, and he has come for follow-up, right? His CKD, he's a diagnosed patient with chronic kidney disease, and his CKD is due to long-standing uncontrolled hypertension, right? So the first part might be the medicine part, where your task is to take a short history and counsel the patient on his further management, right? So this was actually one of my cases when I was doing my final exam for my long case. So I take a history of a already diagnosed patient. So these sort of cases are management histories. So the diagnosis is not a mystery, it's right there. They will tell you the diagnosis, you have to evaluate the management, right? So those sort of things you will have to do as well. So the counseling part might come up in different aspects, so they might come here as well. So the counseling thing, I will sort of give you a basic introduction into how to do a counseling station. So basically in counseling, so this is basically a medicine station, but I will just tell you how to do a counseling station. So in a counseling station also, it's also important to start with your introduction. So you introduce yourself and build rapport. You tell who you are. I'm Dr. So and so, I'm the junior doctor here, or I'm the consultant here, stuff like that. So then you ask them, are you okay to speak with me? Are you okay with the language, right? Can you speak with me now? Do you want someone with you to speak? Stuff like that to make them comfortable and to build rapport, right? And then you can take a short history as well. If that's there in your task list, if that's there in your scenario, that's what you expect, then you have to take a short history as well. During the history, in these counseling sessions, you are expected to sort of show a little bit of concern for them as well, right? So you need to ask, is there something troubling you? Is there something on your mind that you want to ask? So you have to evaluate their concerns, right? And then you need, and in certain things, especially management stations, you need to sort of ask about their expectations. So this was relevant for our earlier one as well, where we counseled regarding family planning method. You have to ask their expectations. So they might know the family planning methods. They might have some understanding, right? So they might come out and say, okay, doctor, can I get this? There is this implant, there's this thing that you put in your arm. Can I get that? So you should ask that beforehand, right? So you should come out and try to gauge you should try to find out their expectations, right? And then you have to give a brief relevant investigation information regarding whatever management thing you are doing, right? So if it's dialysis, or if it's what this transplant, so you need to give them their information regarding that, right? So you have to undergo dialysis, this is what dialysis is, so you will have to come at regular intervals, and there will be need to do a surgical procedure to make this that the AV shunt, stuff like that. So you will need to explain a little bit about that. And then it's very special in foreign stations, they are very concerned about how you address the patient's emotions, right? So in these stations, as in the plab and those exams, especially in the postgraduate exams as well, they will have the patient sort of break down in front of you when you're giving bad news and chronic diseases, stuff like this. So then you need to be able to deal with that as well. So we don't know whether they will do it in this. They have done in earlier cases like that, they have sort of briefly done that. So here also, that's a very possible scenario where they have the they have told the role player, when you are telling about the procedures or a big thing or bad news, they are supposed to break down and cry, right? So then you need to be able to sort of address that emotion, right? So that's another part you need to be able to do. So when they have a sort of non-verbal stuff as well, you need to pick up, right? They won't come out and say I am sad and stuff like that. They will show that emotion, they will start crying or they will be looking down. So you need to pick up on that, and then you need to address the emotions, and then use you need to empathize with them. You need to show empathy. I understand this could be stressful. Do you want to stop right now? Is it okay if we go on? So you need to be concerned about that as well. And at the end, you need to give the follow-up plan and stuff like that as well. So if it's a okay condition, you can reassure them about it. If it's something that needs to be referred, you need to tell them about the referral. Or if it's something that you need to be followed up, you need to give a follow-up plan as well. And at the end, you need to give them time to ask questions. This is important, right? At the end, you need to ask, do you have any questions for me? And if it's good, you can ask them intermittently during your counseling session as well, right? Okay. So we go on to the community medicine part. So now this is assuming this is a NCD and this has been caused by uncontrolled hypertension. We will go on to the community medicine part. Can I have a volunteer for this as well?
Yes, sir.
Good. Sound good. Right. So this can be, so the case, he got CKD due to uncontrolled hypertension, right? So if we can prevent this by early detection and management of the hypertension before it goes into CKD. So what type of a prevention is that?
So it's primary.
Is it primary? What is primary prevention?
The prevention of the risk factors.
Yeah, you take out the risk factor, right? So can you take out hypertension? Can
You
you
can't.
feel? You can't. So then what is this?
Primordial, no?
No, other way, other direction. Secondary, right? So if you detect diseases in their early stage and you take action to manage those diseases, that is called secondary prevention, right? So hypertension, once established, it doesn't go away. You can't cure hypertension, it's always there. So what you can do is detect it early and manage. So that is secondary prevention, right? Primary prevention is where you identify a risk factor and you amend that risk factor. You either completely remove this risk factor. So if like in a smoking patient, if you identify the smoking patient, give certain interventions like brief interventions for alcohol, stuff like that, and you remove that, you turn that person into a non-smoker. That is primary prevention. He does not have the risk factor anymore. In secondary prevention, what you are doing is you are managing the risk factor, you are controlling the risk factor and keeping it. Primordial prevention, what is it? You are not letting the risk factor even come in contact with the patient. You are removing it from the environment. Like you create no smoking zones, right? So then people can't even smoke there. So then the risk factor will not come into effect. So what is the other one? For what is tertiary prevention? What is that? That means disease as the risk factor has been there. You have the disease as well for a long time. Now what you are doing is you are trying to control the morbidity and prevent mortality, right? So the sequelae, the complications have all come up, right? Now you are doing you are limiting the complication. So that's what we do in CKD. Now CKD has arrived. Now we are doing dialysis and stuff like that. So that is tertiary prevention. Tertiary prevention, right? So you need, so these can come. So you need to have the theory parts are very important. So they can come up at any time during these stations, right? Right. The next question: where does routine screening for NCDs occur in Sri Lanka for the general population? For the general population, right? Where does it happen?
The hospital clinics is one place.
Yes, hospital clinics. Is there a special clinic where we do NCD screening?
Healthy lifestyle center.
Exactly. So healthy lifestyle clinics is the general population clinic. So in addition to that, there are two places. Healthy lifestyle clinics is the main one. In addition to that, you also have medical clinics and clinics at the hospitals. But the healthy lifestyle clinics is what is most preferred, what we are trying to push towards. We are trying to get all the general population, a specific population, into these HLCs, right? So that is the target area. So can you tell me a little bit about what you know about HLCs? What are HLCs, where they are, and how is the screening happening in HLCs? If you know, if you don't know, that's fine. We can cover those.
It's organized by the MOH and the PHI.
No, not exactly. Not the HLCs.
So I can't remember.
Yeah, oh, that's fine. That's okay. So HLCs, I can't remember if I had any slides. No, right, never mind. So HLCs are called healthy lifestyle clinics. These are organized at primary care institutes, the lower level hospitals, PMCUs, divisional hospitals, and some base hospitals, right? Not the MOHs. The MOH has nothing to do with the HLCs, right? These are done in these lower level hospitals. They will have the HLCs, the healthy lifestyle clinics. And they are the people who are supposed to attend are above 35-year-old, all the above 35-year-old people, males and females. They are supposed to attend these clinics. And how they can attend? They can self-refer, which means they can come on their own or they can be referred, right? They can be referred by the GPs, they can be referred by the public health staff. So that is where the MOH staff comes in. The MOH staff, the MOH, the PHI, the PHMs, they can refer the patients to these HLCs, and there the screening will happen. So the screening purpose, there will be, screening for, the height, weight, the BMI measurements, then evaluation of blood sugars, then cholesterol levels, measurement of blood pressure, and then lifestyle assessment and lifestyle modification advice, health education, health promotion. So those are the stuff that happens in the HLCs, right? Right. So next, what is this chart and how do you use it? Can you remember what this is? So it's okay if you don't know, right?
I can't remember.
Right, that's fine. So this is the chart that they used. We'll go and look at the marking scheme and come to this as well. So right, so this is the marking scheme for that. So like I mentioned, please be thorough on your theory parts. Your theory parts might come up here as well. So it's very easy to put these community medicine parts into your clinical parts as a part 2 or part B and ask these questions, because it's specifically mentioned in your the ERPM part 2 guideline. The questions, the stations can be mixed content, right? So any of these can come. So you just be thorough about the prevention. So there's primordial, primary, secondary, and tertiary prevention. So you need to have an idea about that and have the what HLCs are, healthy lifestyle clinics. So you only need to know a few details, right? If you know this much, that is enough. HLCs are healthy lifestyle clinics. Adults age 35 and above are supposed to come there unless they are diagnosed, right? This is a screening center. So if you're already diagnosed, you don't have to come. You can be followed up at the medical clinic. That's fine, right? And even younger people can come if they have certain risk factors, like they are extremely obese, they are smokers and stuff like that. So this is an additional point. So even younger people can come if they have certain risk factors, and they can come on their own or they are referred by the public health staff. So and they are held at these small hospitals, the primary medical care units and the divisional hospitals and some base hospitals, right? So the screening, this includes blood pressure, blood glucose, lipid profile, BMI, waist circumference, and lifestyle assessment. So these are the services which are offered at these HLCs. So these charts, what I showed you earlier, these are called a WHO. The proper name for this would be the CVD risk prediction charts or the cardiovascular disease risk prediction charts. So these charts actually predict your risk of having a cardiovascular event in the next 10 years. Right? This is what they do. And these are in all the HLCs. They will have this these risk prediction charts. They are supposed to be used for every patient. You don't need to know a lot about this. All you need to know is there's already an algorithm on how to manage this. If you are anyway given this, just know this is a, if you know this much, this is enough. This is the cardiovascular disease risk prediction charts. If you know that much, that would be enough. If they ask more, just tell that this is there in a booklet, and in the booklet the instructions are also given, right? And what happens is all the information you need to use this chart is given in the chart itself, right? What you do is you take a patient, and depending on the characteristics of that patient, you enter that patient somewhere here. So you can see that the age is given on this side, right? The age is here. Then on this side there will be two charts, one for people with diabetes and one for people without diabetes, right? And then depending on a man or a woman, again you have two sets of charts. Then again it's divided into whether you are a smoker or non-smoker. And then again on this side you have the the blood pressures, the systolic blood pressures, right? So depending on all of these features, they will fall into one of these boxes, and each of these boxes predicts the cardiovascular event risk in the next 10 years, right? And then depending on the risk, you will give them certain advice, right? If you know that much, that would be enough. I mean, you don't need to memorize, for this, the red ones you do this, the orange ones you do this. If you know this is the cardiovascular risk prediction chart, there is a booklet in all of these HLCs, they will tell you what to do. That would be more than enough, right? The basic principle is if they are in these red zones, what we try to do is get them down into these lighter colored zones, right? We try to reduce their systolic blood pressure, we try to make them non-smokers, and on some of these you will have the cholesterol level as well, right? You try to control the cholesterol level. So by controlling the risk factors, we try to get them into these lighter colored zones. So that is what we do. And in the booklet they will tell you what exactly to do, and it's general stuff like counsel on diet, physical activity, smoking cessation, avoid harmful use of alcohol, general stuff like that. And the follow-up duration will change depending on the color, right? That is all. Right. Do you have any questions regarding that NCD management and stuff like that? Or regarding counseling stations? Right? Another station you might get is breaking bad news, right? In community medicine, of course, you don't. It's difficult to find a scenario where you will have to break bad news, but in other clinical fields, you might get, right? So be ready for those things as well. Right. So we move on to the next one. So station 3. Right. So this is more along the lines of a pure community medicine station. So can I have volunteer for this one as well? So it's okay if you don't know this stuff. We will cover all the things that are here. Can I have volunteer for this?
Okay, sir, I will volunteer.
All right, good, Manuli. Right, so this is, you are given this form. So imagine you go into this station and this form is there, right? So can you identify this form? What is it?
This is H544 form,
Good.
which is used for notification of communicable disease.
Sorry, this is used for?
Notification of communicable disease.
Exactly. And who has to fill this?
Any medical officer can fill it, including the intern medical officer. Yeah.
Exactly. So good. So this is the H544 form which we use to notify communicable diseases. So what diseases do you have to notify using this?
Okay, like there are categories. There's group A diseases and there are group B diseases.
Right.
The diseases that are falling under group A are cholera, plague, and yellow fever. And the group B
Right.
diseases are acute flaccid paralysis and measles, rubella, and congenital rubella syndrome. And
Lots
then
of
we have
diseases. Right.
like the stuff, other diseases like chickenpox. There is encephalitis, meningitis, mumps, mm, diphtheria, and even if there's
Right.
food
So there are
poisoning,
lots of diseases, right?
yeah,
Lots of diseases.
that's
Among those, there's this as well. So if you want to find out, if you can't remember those diseases, where can you find them? Are they listed out somewhere? So they are listed out on the
there's
back.
a list of notifiable diseases in Sri Lanka.
Yeah, it's on the back of this form, right? And so this is the front of the form. On the back of this form, just to note, on the back of this form, these two groups of diseases are there, right? So if you are unsure of which disease, which group it is, on the other side, those diseases will be there. So good, you know about that. So next question. So identify two deficiencies in this form. Manoli?
Yes, I'm checking. Okay, the patient has been admitted on the 6th of February, but then the form has been filled on the 10th of February. So
Exactly.
there's a delay in that.
Yeah.
That is one
Why is
deficiency.
that? Why is that wrong?
Because like even when you suspect that this is the disease, you should notify.
On suspicion. So what's the other thing?
Still trying to find.
Right. So the other two things are
Okay, the disease, it's not H.A. Pereira.
sorry,
The name has been written on the space for disease.
the name of the patient,
Yeah.
disease. Yeah, that's also yeah. Good. So there are two other. I only asked two deficiencies,
And
but yeah.
no.
Right. So there's actually three deficiencies here. Number two, you also correctly identified. The diagnosis or the disease is not given, right? It's not given. It should be given here. The next one is this is a little bit subjective, but ideally now what we recommend is you have to have the telephone number, right? Right. There's no circular as such, but there is an unwritten sort of thing. You can't. It's very difficult to trace people with the address alone. So you are supposed to put the phone number here as well. So as medical officers, as future house officers, when you are writing this form, please include the working phone number as well in this, right? In the contact details, include a working phone number, right? And if possible, you can obviously put more investigations as well, but bare minimum, that's fine, right? Right. So of those three, any two, that would be fine. So the first one also, I hope everyone understood. This H544 form we fill on what? Suspicion, not on diagnosis. You on suspicion, you fill it and send it in, right? And this can be done by any officer, house officer, SHO, even consultant, and even in the what? Private sector. So they might ask the question like that as well. So even in the private sector, you should send in this notification form. Even in private hospitals, GPs, they are supposed to send in this form, right? Right. So next question. So can you just briefly describe the route that this notification form takes? From the ward, where does it go?
Okay. The medical officer will notify on suspicion, will fill the H544 form, and will document on the ward notification register, and then we'll hand it over to the after that we'll inform the that is infectious the nurse who is handling that infectious control nurse, I guess. Yeah, we'll inform the infectious control nurse, and then she will document on the hospital notification register and will post it to the patient's MOH area, and then patient's MOH will document that on the notification register, and then the area PHI uh, will mark that on the inward register, and we'll do the home visit. In that, he will confirm the diagnosis and will check about the compliance and the follow-up of the patient, and see whether if any family members if there are contacts who are affected as well, and we'll check for the source of infection, uh, and then he will fill the outward register and H411. And then based on H411, he will update the notification register, that is H411A, and will inform the EPID unit. And if the disease is either group A or group B, one of like if it falls under those categories, then he needs to record that on the infectious diseases register and WRCD, and will send to the regional epidemiologist as well as the epidemiologist.
Okay. So good. You described the procedure in detail. So right. So the procedure is basically okay, right? So in this question, it'll be a little bit more specific, like you said. If this disease is group A or group B, so we know this is dengue antigen positive. So it's definitely group B. So in your questions as well, you did good, right? So this is a general thing. When people are answering, they sort of answer in this general format sort of way, right? So when you are answering, try to stick to the scenario which is given, right? This is dengue positive, so you say, okay, fine, this is put in that register, right? So you can go ahead with that, right? So the other ones, perfectly good, complete, right? You answered my next question as well, some of my next question, which is the part, what are the PHI duties once he receives this form? So you described most of the duties, right? So in addition to that,
I think I didn't tell about control measures, right? He will take control
yeah,
measure.
yeah, that's the other thing. Right? So then
And
at
maybe
the,
health education.
yeah, so basically, so I will describe this at the end because you said most of the things. So your process was okay, your procedure was okay, and the PHI duties also, most of the things you said. So what are the other surveillance mechanisms we have for dengue? Just one
There
other?
is dengue sentinel surveillance.
Right, sentinel surveillance. Another one, if I could. So this is routine surveillance via the H544. There is also a special surveillance, right? There is a special surveillance mechanism for diagnosed dengue disease, diagnosed dengue patients, right? So sentinel surveillance is you sort of choose one spot as a sentinel site and you survey the disease in that site, right? We have certain MOHs and we have certain hospitals we have established as sentinel sites. So then we get a running count of all the dengue patients who get admitted in those areas. So there's a sentinel surveillance that happens. There's a routine surveillance which happens through this form. And then we have a special surveillance which happens when the patient is diagnosed. So there's another separate form which you have to fill on diagnosis, either dengue fever or dengue hemorrhagic fever. That's a little bit more big. And on diagnosis, you have to send that in as well, right? So good. So I just take some time to go over the communicable disease notification system in a little bit, just a little bit of time, because I found that some people have, a little bit confused about it. Just to recap, notification, it's a legal requirement. It should be done by every person. There is there's an ordinance called the Quarantine and Prevention of Disease Ordinance, which mandates, right? It mandates the notification of these diseases. And the notification should be done by any medical practitioner, government or private, at any level, at any designation, right? And it should be notified to some, what you call the proper authority. That's how it's defined in the ordinance, and that is the MOH of the patient's area of residence. In addition, like Manli said, there's this group A diseases. Those group A diseases, those 3 diseases, they should be informed in addition to the Director General of Health Services. There's a Deputy Director General of Public Health Services, and at the epidemiology unit, the head of the epidemiology unit is called the Chief Epidemiologist. Those 3 people also have to be informed in these Group A diseases, because these are diseases with a high likelihood of going into outbreak situations, right? Which are basically now been eliminated in Sri Lanka. So in the routine notification system, there's a part which happens in the hospital, part in the MOH, and part in the field. So the hospital part starts by filling the H544 form. So these H numbers, there's only few H number forms you have to remember. This is one of them. The H544 form, remember that by the number. So that's the notification of communicable disease form, and that is filled on suspicion by the treating medical officer. And then these are the notifiable diseases, group A and B. Like I said, these are on the other side of the notification form, right? If somebody asks you, if they ask you where are these notifiable diseases listed, tell them it's on the other side of the form, right? It's there, right? So like I mentioned, the group A diseases, in addition to the MOH, they should be notified to these people as well, as soon as possible, not just via the form, but by telephone, by fax, by telegram, basically immediately, right? Once and then moving on, once you have filled the H544 form, you have this ward notification register that should be filled, and the hospital will have its hospital notification register. And that entire process is the hospital notification register is usually with a person called a nursing officer, called the infectious control nursing officer, or the ICN. So they will be in charge of that register, and afterwards that form will be sent to the relevant MOH, right? And the MOH, he has certain registers, he will put them into the register, and then he will send them to in addition to that, the private hospitals and GPs, they are also supposed to send. That's fine. So then the MOH, he has to send to the, if there's an SPHI, through the SPHI to the relevant area PHI. And on the way, there are certain registers that he has to update. And then at the area PHI, we go into the field and do the field activity. So that includes confirming the diagnosis. So remember, this was notified on suspicion. So now he has to confirm the diagnosis, ensure compliance. If there's some sort of treatment ongoing, he has to ensure the compliance. Contact tracing, especially in cases of TB, stuff like that, you have to trace the contacts because you have to do contact screening. Then locate a source, control measures, health education, and then these formats as well, right? Right, so you describe the diseases as well. So in addition, after the PHI does the field investigation and comes back, then they have to fill in certain registers and update the disease on certain spot maps. Spot maps are these maps there are in the PHI's office. So he has to update those maps. Like if it's a dengue case, then he has to put a new pin in his map saying that this is a new dengue case in this area, right? And then there's a back notification. So the it goes back to the MOH, and the MOH has to report to the higher level, the regional epidemiologist and the epidemiology unit. So this is done by something called the weekly return of communicable diseases, or the WRCD, right? If you have a general understanding of that, that would be enough, right? Right. So good, you did most of the you hit most of the criteria, the specific points I want to highlight. And just a additional point, now the WRCD and most of this special surveillance is done via online, right? For the special dengue special surveillance, we have an online system called NATSIS. You don't need to know the names, just know it's online now, right? Right. So then we go on to the next station, right? Right. Can I have volunteer for this station as well? Pasindu, how about you give this a try?
Okay.
Right. So you are, there's no scenario here. So you are the medical officer of health in a immunization clinic, and there's a mother who's bringing her 1 year, 6-month-old child. So she's 18 months old to the immunization clinic of the MOH. The following is the CHDR, right? So I'm sorry, this should be a little bit more filled. Just imagine that it's filled up to here, right? So now what is your plan of vaccination for this child?
So for 18 months,
Where would you start?
I have to start from the OPV.
Sorry?
OPV.
Only the OPV? So just imagine these two, all these vaccines are given. I forgot to fill in this. Imagine all the 2-month vaccines are given. Afterwards, nothing is given.
Okay.
Right. So then
Okay.
what is your plan of vaccination for this child?
Also, then I have to complete all the 4 months, 6 month vaccine, 1 year and the 18 months vaccine.
Right. So where will you start with? What vaccination will you start with?
From the 4 month, I have to start with the OPV, FIPV, and the pentavalent vaccine.
Right. And how will you sort of establish a gap between them? So how are you going to give them every other day, or what?
No.
Yeah.
And these vaccines can be given in the same day. A number of vaccine can be given in the.
Any vaccine can be given on the same day, or what?
Sorry, the live vaccine or the live vaccines can be given the same day.
Okay. Right. So this is a question which sort of evaluates your knowledge on immunization principles, right? So good, you know the principles. It's just a question of attaching it to a practical situation. That's the issue here, right? So good, you know the principles. So here, what you have is a patient who's coming with incomplete immunization, right? This is an 18-month-old, now 18-month-old, but only having completed up to 2 months of vaccination. So here you can start vaccination again. So this is a very common situation. People go abroad and they come back, and then you have to restart vaccination, right? So then you can restart, like you correctly said, from where you have ended. So this child last is 2-month vaccination. You can start from the 4-month vaccination point. And there you have this another principle, which is how you have a gap between vaccines, right? So when you're giving vaccines, if you want to give live vaccines, either you give them on the same day, or what is the otherwise what is the gap you should have, Pasindu?
At least 4 weeks gap.
4
between-
weeks, yeah. You should have at least 4 weeks gap between two vaccines, right? So here, of course, because you are giving, these combined vaccines, basically at 4 months you are giving OPV, the pentavalent OPV and FIPV. We usually have about 2 weeks to 1 month gap, right? Here, of course, because there's a pentavalent, that's fine, but because these are combination vaccines, we usually have 1 month gap between the vaccines. So you give the 4-month, then you wait 1 month, and then you can give the 6-month vaccines, which is the OPV and the pentavalent without the IPV, right? You stay 1 month, and then you can give the 6-month vaccination, and then you can stay another month, and then you can give the what, 9-month vaccination, right? Like that. For the 9-month one, you have to definitely wait 1 month again before you can give the 1 year one, right? The 1 year one is missing here, right? So like that, with 1 month gaps, you can complete the immunization up to this point, right? So those are the two principles that you need to know. There's an additional principle regarding how you keep vaccines. Once you open them, we will discuss them if we have time, right? So those are the two principles, key principles you need to know, right? So next question, how would you assess this child for vaccination? So imagine this could be as a role playing one as well. This could be an actual scenario where there is a child or role play, and you are told to assess the child. So how do you briefly assess this child for vaccination in this busy clinic? What are the key questions that you would ask?
So I have asked mainly about this vaccine related any complications with the
Yes.
previous vaccine.
Reactions to previous vaccinations. Good. Next. So will you want to ask about today? How is he today? Is he having fever? Is he not well, having diarrhea, stuff like that?
Yeah, after the current vaccination, we had observed like around 20 minutes. The child.
No, I'm talking about the pre-vaccination, right? Before vaccination, we are assessing. So what are the key questions?
Yeah.
There are 3 main questions that you would ask. One, you did correctly, right? Reactions to previous vaccination. That's fine. Other one?
Others are like, is he having any fever or something acutely at this time?
Yeah. How is the child today? Right? Is she having fever? Is she having any other illnesses? Stuff like that. So if that child was having a mild fever, would you vaccinate or not?
Just a mild fever, we can vaccinate. But if it's very high fever for several days, I would not vaccinate at this moment.
Right. So good. So you have to ask about today's status. If it's a mild fever, especially sinusitis and rhinitis and mild rhinorrhea and stuff like that, that's okay. You can vaccinate, right? High fever, about 39.5, stuff like that. Then of course you have to postpone. Right. So what is the other thing you have to ask? So good. 2 things done. What is the third thing? Pre-vaccination assessment.
In this child, since the child has missed the JE also, Better ask about seizure history.
Yes, past medical history. Past medical history and any specific contraindications, right? So those are the three things that you have. That's all. Right? Reactions to previous vaccines. කලින් ගහපු එන්නත් වලට vaccine වලට මොකක් හරි වුණාද? දෙවෙනි එක අද උණ තියනවාද මොකක් හරි අමාරුවක් තියනවාද? Today is the child having any sort of illness? Is she having fever? Is he having any sort of condition? Next thing, the past medical history. Has she been admitted to the hospital for some sort of condition? Did she have any sort of fits, right? Fits or any cerebral condition, stuff like that. You can ask in the past medical history. Only those three, as you know, not only those three, you can ask a little bit more, but those three are mandatory, right? You have to ask these three questions from all the children, right? All the children who undergo vaccination should be evaluated by a medical officer, right? So in that case, if this patient came with febrile, past history of febrile seizures, and now you are going to give the JE vaccine. Can you give the JE vaccine, Pasidu?
I have to confirm when did it occur for the last time?
Good, very good. So just because that person has had a febrile seizure doesn't mean you cannot give. If he or she has been seizure free for 1 year or more, then you can give the JE, right? Until 1 year has passed, you have to postpone. So very good. What is the contraindication for these pertussis and JE vaccine? It's what sort of neurological condition?
This neurodegenerative disorders like this infantile spasms.
Yeah, it's called progressive neurological conditions. Any progressive neurological conditions, or like you said, degenerative neurological diseases, those are the contraindications for these JE and pertussis vaccines. Right, good. Right, now the PHM brings you the vaccine vial and shows you. Now what would you do and why?
So the center square is like darker than the outer circle. So it's not good for use. Should be discarded.
What is this?
Sorry?
What is this called? What is the... Good, your interpretation is correct. What is this sort of symbol or indicator called?
Vaccine vial monitoring.
Exactly, the vaccine vial monitor. So start from there, right? So when you're answering, so good, you're answering correctly. I'm just telling you these things to structure your answer better. So if you can give a structured answer, that would get you more marks, right? Because even in my marking scheme, I said at the end, if you identify this as a vaccine vial monitor in the beginning, there's some additional marks there, right? So this is the vaccine vial monitor. So this is, what does this show?
It shows the heat sensitivity of the vaccine.
Yeah, it's a heat sensitive, or more specifically, it shows the cumulative heat. If you can remember that, it's okay. If you can't, but fine. If you can know this as a simple as a heat indicator, that's also fine. But specifically, this shows the cumulative heat, amount of heat that this cumulatively this vial gets exposed to. This is an indicator. So if this gets exposed to higher temperatures, more than what is the highest level? What is the range, temperature range for vaccines?
2 to 8 Celsius.
2 to 8 Celsius. So if it goes more than 8 for long periods of time, this will become darker. So how does it start off? So it starts off light. The outer circle is dark, the inner square is white. And then as it gets more and more exposed to heat, the inner square will become darker and darker. So at this stage, it's called stage 1, when it's completely white. And as it sort of gets a little bit darker, but still lighter than the outer circle, it's called stage 2. And at one point, it will be the same color, right? It will be the same color. That is called stage 3. And if it's darker than the outer circle, then it's stage 4. So stage 3 and beyond, you don't use it, right? Right. So good. You know all these things. Oh, it's all about, putting it into a structure, right? So good. So next question. After about 10 minutes of receiving the vaccine, the child developed itching, generalized erythema, and urticaria. What would you do? That part is not there, but what would you do?
It's so it still affect only the one system. I don't think it's a anaphylaxis or something. So
Yeah. So what
I
would you
could
do?
observe.
Imagine this is the scenario, right? You be this could be even an emergency scenario, right? You are given a mannequin and you are told, okay, this child developed itching, erythema, and urticaria. What would you do? If you are going to look for something, you can ask. If you want to know some other details, findings, examination findings, you can ask. So what would you do next?
So then I will check the respiratory system.
Okay. How would you check? So what is your main concern here, Pasidu?
Main concern like he's developing anaphylaxis.
Whether it's anaphylaxis. Good. So
Mm.
then you can start your answer like that. So this is a child who is in that 20-minute observation period after vaccination. So my primary concern is whether this child is having a immunization anaphylaxis to the vaccine. And the itching and the generalized erythema and the urticaria, that is more towards anaphylaxis. So I want to know about whether the other organs are affected. So you would check for other features, see whether she's, there's a hoarseness of voice, stride. You can check whether there is swelling of the lips, angioedema, stuff like that, right? You can, I don't know how the scenario will actually go, like this can be asked in many different ways, right? So I'm just giving you a overview of how this can go, right? So imagine, okay, fine, this is going towards anaphylaxis. She's having what? Tachycardia, tachypnea, and now she's getting hoarseness of voice as well. Now what do you do, Pasuma?
So then I had immediate attend to the child and I have to give the IM adrenaline.
And you had to do other things as well, not just the adrenaline. This is an emergency situation, so you have to lie the patient down, elevate the legs, the emergency management stuff, right? You learn in medicine. So those things don't forget, right? Eva karala ඊට පස්සේ adrenaline. Yes, good. So the adrenaline is the main thing, right? So in immune anaphylaxis, don't hesitate to give adrenaline. So another way this can be asked is you might have to differentiate between a fainting or panic attack and anaphylaxis. So you need to differentiate those two as well. So you can just put a table and list out those two for you to learn, right? So basic management, even in community medicine, don't forget your medicine part, your general emergency part, your ABCs. Do according to that, right?
Yes.
Right. So next final part. So then this child is brought to the closest hospital. He was fine, but just for further management. In addition to the management of this child, what needs to be done additionally at the hospital?
So then, since this is a serious adverse reaction to the vaccination, so we have to inform through this adverse reaction following immunization pathway. So we have to inform MOH, the hospital, and the MOH will inform the regional epidemiologist, and he will inform to the epidemiology unit. And from there, they will update this adverse effect following immunization, and also they will inform the WHO adverse immunization.
You're on the path there. If you identify this as an adverse event following immunization, and if you mentioned about needing notification, right? So even the hospital has to notify this as an AEFI. There's a special AEFI form. Using that form, the hospital has to notify the area MOH. That would have been more than enough. I was expecting the hospital management only, except the clinical management. What else would you do? And that is what is expected, that they would send in this notification form. Rest of it, what you said was correct. So there's a notification register at the MOH, and at the end of the month, you send in this notification return to the regional epidemiologist and the epidemiology unit, and certain out of that would be sent to the WHO, and in the middle, the MOH has to investigate the serious AEF files as well. So those are also there, right? So good, you did very well. So
and I also have to mark this event in the CHDR as well.
Yes, good. So that's the other thing. So you can mark in the CHDR. There's a column in the CHDR for adverse events following immunization. So you can mark it there as well. Very good, right? So this is the marking scheme. So you hit most of these. All you need to do is just structure your answer, right? So just to recap what was already said. So the vaccination procedure, you need to know how the pre-vaccination screening is done, how the vaccine is inspected and prepared, and then the vaccination procedure, and a little bit about the post-vaccination observation and documentation. So before vaccination, you need to take consent. That's just informed consent, and usually it's not written consent for the EPI program. What we take is implied consent. If they bring their child, that means they give consent, right? For the school health program, we usually take written consent. We tell them to get certain forms signed. Pre-vaccination screening, at the minimum, these three things should be asked. So there are false contraindications to vaccinations as well. So these mild illnesses without fever and even mild fever, they are not contraindications. Family history and past history of conversions, just because they are not contraindications, right? So in addition, after all those, the vaccine vial has to be inspected. That's where impurities and the vaccine vial monitor will come up. So you need to know how to interpret that as well. So we will skip all these, and post vaccination you need to observe for 20 minutes, right? You need to observe for 20 minutes, and then only will you tell them to go home. And even then you need to tell them what to expect, right? There will be fever coming up, people, child might be ill, so those things need to be advised, right? Sorry. So immunization principles we talked about, 2 live vaccines, all of this we talked, right? And then the cold chain, right? The cold chain, the vaccine vial monitors. So this is the vaccine vial monitor stages. So you need to know to interpret this, right? This is a very simple thing. It can be very simply be given as a OSCE station. You might be given this vial to interpret, right? Okay. So good. Overall, very good. Right. So we go on to station 5. So for this also, I need the volunteer.
I'll give it a go.
Yeah, sure. Good. You did the previous one as a good. It's good practice for you. Okay, so these are the candidate instructions. You are the MOH working at child welfare clinic at an MOH. A mother of a 4-month-old infant comes, and she's expressing concern that she's feeling that her breast milk is not enough for the child, and she wants to start formula milk. So your instruction is take a brief relevant history. You don't need to do examination. If you want some examination findings, you can ask about it, right? And you can ask any other information as well, and you have to counsel the mother appropriately, right? Imagine that the PHM is also there. So if you want the PHM inputs also, the PHM is also there. You can ask about the PHM details as well, right? So imagine I'm the mother. So you can, so I'm coming with the concern that my breast milk is not enough for my 4-month-old child. So your duty is to take a brief history and counsel me, right? So go ahead.
Okay. Well, good evening. I am Dr. Nipuni, and I am the MOH of health here. And I understand that you are having some concerns about your baby. Are you comfortable in carrying out this conversation in English or Sinhala?
I'm comfortable in English, doctor.
Okay, all right. So I'm here to help you with that concerns you have. So can I please know your name?
So my name is Mrs. Amali Pereira.
Okay, Mrs. Pereira. So can I know a little bit of details about your baby? How old is your baby?
He's 4 months old, doctor.
4 months old. And also, can you remember what the weight of the baby was when he was born?
He was 3 kilograms, doctor.
3 kilograms. And what is his weight today? Was it measured?
Yes, it's measured, doctor. It's okay, doctor. The weight has increased now.
Okay. And so what about was his weight marked on the CHDR? Do you have that chart?
Yes.
Or ask the midwife for it?
CHDR is perfectly normal weight gain, right?
Okay, all right. So can I know about if the baby was breastfed as soon as the baby was born?
Yes, doctor.
And there was no problems until recently?
No problems about until 2 weeks ago, doctor. That's when I just felt that I didn't have enough breast milk, doctor. It just felt that I wasn't giving enough to my son.
Okay. Usually, how many times a day do you do the feeding?
I feed about every 2 hours, doctor.
Every 2 hours. And how long is each time you feed? How much time do you feed usually?
Around 20 minutes, doctor.
Around 20 minutes. And what about, does the baby latch properly? Does the baby attach to your breast properly?
Yes, doctor. There's no problem there, doctor.
Has the midwife assessed your breastfeeding technique as well?
Yes, doctor.
Okay, all right. Has there been any recent illnesses in your baby? Did he get
No,
ill
doctor.
recently?
No.
Any fever, diarrhea, anything?
No problems, doctor.
Okay. And what about his nappies? Is his urine passing as normal, or has there been a change recently?
It's normal, doctor.
Okay. And is his development, has it been marked in the CHDR as appropriate for his age?
Yes, doctor.
Okay. And his weight for age and everything is marked as okay by the midwife, right? Okay. So has there been any signs of other notices that you have, any other signs that you have noticed in your baby, any changes in your baby's skin, or
No.
and what about any difference in his behavior? Has there been anything? Has he been sleeping a lot more?
No, doctor. There's no change in the behavior. He's a little bit difficult to put down at night, but otherwise he's okay.
Okay, so right now I think there is no problem developmentally. So and his growth is as normal. So what we can do is, I guess, we can
But
observe.
I feel that my breast milk is not enough, doctor. Is it okay if I start formula?
So formula is an option, but your baby seems to be normally growing well and right now is having enough wet nappies. So I think what we can do is maybe we can observe a feed. The midwife can help you with that, and we can observe one feed and like make sure that everything is working okay and that the baby is latching properly and the feed is happening as usual. And so what we can do is, if so, usually the guideline says that up to 6 months we should exclusively breastfeed, because there is certain immunity factors that the baby gets from you, and certain nutrients that the baby exclusively gets from your breast milk. So what we usually encourage for mothers is to try and push for breastfeeding. And since currently the baby is well hydrated and the baby is growing as normal, what we can do is we can see if there is any issues with your breastfeeding technique or anything else, or any signs of discomfort around your breast or any clogged milk ducts, and we can eliminate all of those causes. And if that's not an option, then for the next resort, and if your baby's growth is faltering, so that basically means in 2 weigh-in sessions, if the baby's growth curve is kind of flattening a little bit, then we can go in for other kinds of uh, feeds such as formula milk. And if this happens in the 6 months parameter, we can also In 6 months, we will usually start with our complementary feeding as well. So what we can do is we can just observe for now and move on from there.
Okay, doctor.
Thank you.
Right. Okay, good. So, okay, almost 9 minutes. Right. So, good, Nipuni. You have improved a lot. Right. So, this was the marking scheme I generated for this. So, one thing I just want to emphasize here. I'll go for the specific points first, right? So you asked about the frequency and duration of breastfeeding. That's good. That's what you must that you need to assess upfront. You need to be specific about the urine output, right? Don't just ask, is it adequate or is it early, similar as earlier? Ask how many nappies or ask how many times the child has passed urine. If it's more than 8, around 8 to 10, then it's good, right? Then just ask about the you asked about the sleep and the activity level of the child, so that is good. That is another indicator that if the child is not getting enough feeds, that would be an indicator. Then little thing you missed was the maternal anxiety part. So you can just ask about, okay, why are you concerned about this, right? So if you sort of elicited that, my sort of response would be, I was getting a less of a fullness feeling in the breast, right? This is a common concern among especially among primary mothers. So that's another thing you didn't ask in the initial history. Always take a basic biohistory, right? Name, age. You did it in the first one, you did, right? You asked the job and all, right? Or job and the education level. You can just basically ask, so you can tailor that message to that person, right? So in that after that you need to ask why this person is concerned about this, right? So as the child is growing, that feeling of fullness, it won't be there like it was earlier, because the child will be feeding more, so that fullness of the breast will not be there as it was earlier, so that will grow less. And sometimes this is misinterpreted by certain mothers as to think that they have not enough milk, right? So that might be the concern. So if you can address that, if you can sort of address the main anxiety point of that mother, that would have been better, right? So then you evaluated the weight and stuff like that. So that is also important in a case like this, where you have to deal with the weight gain, feeding and stuff like that. Always ask the mother for the CHDR, or if the CHDR is nearby, you have to take it and you have to be able to interpret that CHDR, right? And I can't remember if you asked about the past history of the child. You did ask a little bit about the birth weight and stuff, so that is good. Just ask a little bit about the past history. It's only 4 months now. Were there any issues up to the 4 months? That stuff like that, just ask. And in the examination, you can ask in the rather than the history, just say that in the examination I would look for features of dehydration. So you need to know the features of dehydration as well. Sunken eyes, increased skin turgor, stuff like that, right? And then you asked about the development as well, so that is also good. So that is also something that's needed, right? And you can ask the PHM about the breastfeeding technique. So usually in these feeding issues, the PHM will actually do the breastfeeding assessment and then come to you with the mother. So then you can ask the PHM directly, have you assessed the breastfeeding of this mother? How was it, the attachment and stuff like that? You can ask from it, but you ask from me also, that's fine. So what is expected is that either you have to observe the breastfeeding technique in front from the mother, or the PHM has to observe and tell you the findings. Either of those two are fine, right? But you have to observe. Somebody has to observe, right? And then you asked about the development, which is good. One of the more key important things here in Sri Lanka, I want to emphasize: never give formula as a option, right? You sort of mentioned that you are open to the concept of formula. Don't do it. Our community medicine consultants and neonatologists and pediatricians, many of them are very averse to formula, right? It's, we have a separate code for breastfeeding where we have banned these companies from even advertising to mothers or even coming close to health professionals with any incentives, right? That's how much we have. So never ever sort of give formula as an option, right? you correctly identified that this child has no issue, right? It's just a maternal concern. The child is okay, development okay, growth okay, no dehydration, stuff is okay, right? So then you gave the follow-up as well. You sort of a little bit, you rambled on a little bit. If you can just shorten that, that would have been good. Just say, okay, the development is okay, the growth is okay, your child is not dehydrated, and she's only 4 months old yet. So we can continue breastfeeding and we can monitor with regular growth monitoring. So come to the growth monitoring clinic, measure every month, and if it goes down, we will see. If needed, we can start complementary feeding early, right? From 4 months onwards, you can start complementary feeding. So never give the option of formula, right? So this can be a common scenario. I remember because this was given as a scenario for us, right? When we were medical students in our this, I can't remember the module, nutrition module or something like that. This sort of, not scenario, this was given as a question, a CQ question, right? Where we had to give an answer, and if you gave a formula as an answer, that was completely wrong, right? So now it can come to you as an OSCE station. So never give formula as a option. Formula will be started by a consultant if there's a necessary. This child, obviously there is no indication. If there is some growth faltering, you can start complementary feeding, right? Other than that, you are completely on point, right? The other things, most of the things you emphasize correctly, and you also went into the advantages. So that's another important thing. So when you want to push somebody towards continuous breastfeeding, emphasize advantages to the mother, there's advantages to the child. Just mention one or two, right? That would be enough, right? Right. So you re-emphasize that and advise on follow-up as well, right? And encourage and praise mother's existing confidence, that's also fine. And then overall communication skills, you are good. You showed empathy, supportive tone. If there was any emotional stuff, I didn't act those out here. In your real case, make sure to keep an eye on the non-verbal cues of the mother, right? Just keep an eye. They might be told to do this and that, so you need to pick up on that if that happens, right? And at the end, always ask, do you have any more questions for me, right? And arrange the follow-up. You can come next month for the clinic, for the weighing, and we'll see with that, right? Stuff like that. Always arrange for the follow-up as well at the end, right? So good. Overall, you did very well. Only small things to fix. So good, right? Right. Any questions up to now? Right. So station number 6. So this is more along the lines of a pure sort of epidemiology and statistics sort of station, which you might get as a, a Viva station, which is certain case scenario. So here you are a medical officer attached to a base hospital. You notice that hand washing compliance and technique among health staff is poor. They are not washing their hands correctly. Right? So you want to test whether a structured education session on hand hygiene will improve their compliance with these techniques, right? So this is a hospital, there are certain units. So you select certain units and you give them a health education session, a hand hygiene session, and you display posters near their hand washing stations. And other units, they continue with their routine practice and do not receive any interventions. So then for the questions, can I have another volunteer? Randi, are you okay now? Or? Pasindu, how about we do this also?
Okay.
Right. So what type of a study is this? What type of a research?
It's kind of,
Sorry?
I'm not like, it's a cohort type, is it?
So do you think this is can you remember you divide on the top into observational studies and interventional studies? Are you observing or are you intervening and doing something?
Yeah. So this is, we are intervening and doing something.
Exactly. So this is an interventional study. So you won't be asked about complex clinical trials and stuff like that. Just basically to that basic hierarchy, if you know, that would be enough. So in your hierarchy, at the very top, you have primary studies and secondary studies. Secondary studies is this systematic reviews, scoping reviews, that meta-analysis, those are secondary studies, right? Primary studies is where you go out and collect data and do a research, right? Primary studies at the very top are divided into observational studies and interventional studies. Observational studies is where you observe, you do not change anything, you do not intervene, you just look and observe. Interventional studies, you intervene and decide who gets what. You change certain variables, right? So this is an interventional study. You don't need to give any more information than that. So you have clinical trials, double-blind randomized control studies, stuff like that. Those are types of interventional studies. So if you identify this as an interventional study, that would be more than enough, right? Then observational studies are the ones you divide into these observational descriptive studies and observational analytical studies. Descriptive studies, you describe and try to generate a hypothesis. Analytical studies, you compare groups and test a hypothesis, right? So that's where you get the cohort studies, the case control studies and stuff like that. So here, this is an intervention. So this is an interventional study. Are we clear on that? Any questions there?
Yes.
Right, good. So next, what are the basic steps in designing and implementing a study? Just the basic steps. I don't expect all the steps, but by what you know, how would you carry out such a study? Only the basic steps. Ideally, there are 10 steps, but I'm not expecting all of this here. Just the basic steps. If you don't know, that's also okay. That's fine.
So first we have to identify the problem.
Good. Problem identification. Right. That's already done here. Next.
Yeah.
That's the first step. What is the next
Then we
part?
have to then we have to find a suitable like population to.
So what if this study was already done? So somebody has in your hospital, somebody has already done and published a study. They have already done the intervention and published. So then is there any use of you doing the study? Again. No. So then how can you find it out? By doing what? Something called a literature review. So that's the second step, a literature review, right? This is, of course, it's a very small study, but for any study in general, you need to do a literature review to make sure this study hasn't been done previously. Or if you want to, be more specific in your research question, you always do a literature review, right? So what is the next one? You attended correctly, which is you develop the methodology, right? Study methods. You decide who are the study population. When am I doing the study? Is this going to be an interventional study? Is this going to be a double randomized control study? All that is developing the methods, study methods or the methodology, right? So what is, okay, you develop the methodology and you decide all of that and you come to, you develop a research proposal. Next, what is the main step? You have a proposal. Now what do you do?
Then we have to get the approval and is ethical approval for this.
Good. Now, one part is ethical approval. Where do you get ethical approval from, Asima?
I'm not sure, sir.
It's called a ERC committee, ethics review committees, right? These are the committees which can give ethics approval, right? So you need mainly two types of approval. One, you need ethics approval. Next is the administrative approval, right? For any research, you need ethics approval and administrative approval. Ethics approval you get from ERC committees. These are there in universities, Colombo faculty, Pera, all these faculties have. And then in addition, certain institutes also have. So even certain hospitals, big hospitals, they have their own ERC committees, right? So you can take from there. And then in addition, if you're doing in your hospital, you need the hospital administration's authority to do that. So you need to submit this proposal to the hospital director and get his approval. And if you are doing this in an MOH clinic, you need the MOH approval, right? So approval is that these approvals, ethical approval and administrative approvals is the next step. what is the step after that? So now you can carry out the study. Ne?
Yeah.
What is called data collection. That is the data collection phase. You here, of course, this is an intervention. So you give the intervention and then you collect data on the adherence and stuff like that. And then finally you can do the analysis.
And interpret the results.
Yeah. Analysis, and at the end, what do you have to do? Dissemination. Right? You have to disseminate the results. You have to do the analysis, come to a conclusion, and then disseminate the results. So these are the main steps, right? Expanded, there are about 10 steps altogether, but these are the main steps you need to know of how to carry out a research. This could very well be asked. They give you a scenario and tell you what are the basic steps of carrying this out. So you just need to give a overview, right? So good, you know the steps. It's just about putting them in order. Right. Final thing. After so you do the study, you give the intervention, and after a period of 2 weeks, you find that the people who were given the intervention, they are doing much better. Their behavior is good, right? And hand hygiene behavior is good compared to the people control group. And you do a statistical analysis, right, to compare the two groups, and you get a p-value of 0.03. How would you interpret this result?
Usually for like in studies, we use the null hypothesis and hypothesis, one null hypothesis and this alternate hypothesis we're using. For that, we calculate the p-value. Usually, if the p-value is less than 5%, 0.05, like we would reject the null hypothesis and we'll go with this alternate hypothesis usually. So in this case, it's below the 0.05 value. So we
go smaller.
Yeah, it's smaller than the critical value. So we have to reject the null hypothesis.
Right. So good. You are there. So again, it's about a little bit about the structure. So you started out good. So yeah, that's the starting point. You have a null hypothesis and you have an alternate hypothesis. So how do you decide between these two? You have something called the p-value. So what is the p-value? So the p-value is the probability that this observed result is due to chance, given that the null hypothesis is true. If the null hypothesis is true and there's no association between your intervention and hand washing, what is the probability that this observed result is due to chance? And this says that this chance is around 3%. So, and usually we have a predetermined significance level or cutoff level, and that is 0.05, right? And this value of 0.03 is less than the significance level of 0.05. So what do? We reject the null hypothesis. So our interpretation is that there is an association between our intervention and increased hand hygiene or better hand hygiene. So our intervention has improved hand hygiene. So that is very simply in 3 or 4 sentences. Just that's how you interpret, right? You start off good. You start off with the null hypothesis. You tell what the p-value is. You tell that there is a significance level or a cutoff level. You compare your p-value to the critical value or your significance level. If it is above, there's one interpretation. You do not reject the null hypothesis. If it's less than 0.5, you reject the null hypothesis, right? You do not mention about the alternate hypothesis. Either you reject the null hypothesis or you do not reject the null hypothesis. Those are the two interpretations. And here it's 0.03 less than 0.05. So you reject the null hypothesis, and your final interpretation, that means there is an association between your exposure and outcome. So good. So nice. So up to that, do you have any other questions regarding statistics and epidemiology and stuff like that, right? Statistics, of course, they might ask in various ways, right? Right. So the next station is again a mixed scenarios case. where this is going to be a pediatric case where you are a doctor in a district hospital OPD. A 12-year-old boy is brought by his mother with a history of profuse watery diarrhea for 2 days after taking food from a restaurant, right? On examination, the child is lethargic, has sunken eyes, a weak pulse, and poor skin turgor. Part 1 is pediatric emergencies, right? Diarrhea and what? What management is this? Severe dehydration management, right? You need to know the emergency management of severe dehydration. I'm not going to talk about that, so I'm not the expert on that, but you need to know that as well. That can be the starting point. So you need to know about identification of severe dehydration. There's this, criteria: mild, moderate, and severe. Then you need to know the initial resuscitation, IV access, fluid management, what fluids to give, how much to give. I can remember vague details. I'm not going to tell them because I don't know if it's accurate or not now. So those sort of things you need to know about the emergency management stuff, and sometimes a little bit about the follow-up management as well when they're improving, like you give zinc and stuff like that. So those also sort of things you need to know a little bit about. So I will focus on the next part, the part B. So can I have a volunteer for this as well? Sanka, can you try these questions? Just, to the best of your abilities. Give 3 important duties of the MOH office with regard to food safety in the community. Just 3.
So the MOH can send the PHI to check what the problem is in the area, taking samples and all.
Yes. So food and what? What samples can he take?
Food and water.
Food and water sampling. So that is one duty, right? Food and water sampling. Other thing you mentioned a little bit, inspection. Inspection of what? Exactly. With regard to food, what are they establishing? What is the proper term for that? It's called a food handling establishment, right? This is the proper term. So this encompasses restaurants, groceries, supermarkets, anything. So in this case, if you can't remember the case scenario, this child has taken food from outside, right? So then the PHI is in charge of inspection of this food handling establishment. So that is one. So what is another duty they can do? Just general duties of the MOH officer, the MOH or the PHI, right?
So if there's like a outbreak of any foodborne illnesses, we can go see the cases.
Yes, that's called, in a nutshell, outbreak management. Outbreak response and management, right? So this again can be separate OSCE station, right? What do you do in an outbreak situation? Not many things, right? Only basic steps they can ask, right? So good. So food and water sampling, inspection, outbreak response. In addition to that, they can also do the legal things. They can issue notices, they can seize foods, they can destroy foods, and they can take legal action against vendors who are not adhering to certain criteria of the Food Act or the regulations, right? Stuff like that, right? So good. So these are the MOH duties. In addition to that, there's registration of food handling establishments, education and aware of food, these owners and food handlers, and then there's giving medical certificates and vaccination with typhoid for food handlers. All of these things are duties of the MOH office, so you need to be aware of that, right? Next, so just you don't need to describe, even just tell me the types of food sampling which happens by the PHI. You don't need to describe. So is there 2 sampling types depending on whether you take legal action or not?
Yes, sir.
Yeah, what is that called? It's
So
called,
for the legal actions, I think you take 3 samples.
yeah, what's the term for that? The sampling method. It's called formal sampling and informal sampling, right? So if you know the terms, that would be, formal sampling, you take with the aim of taking legal action. Informal sampling, it's not for legal action, just for our information. Another way we do food sampling is we do microbiological food sampling and chemical food sampling, right? To look for chemical, contaminants, we do chemical sampling. For microbiological contaminants, we do microbiological sampling. If you know that much, that would be enough. For the process, that's obviously how you do. For the formal sampling, you have to take 3 samples. One sample the PHI keeps with himself. One sample they send to the courts, not the courts, the lab. They send to the lab, and the lab will test that. And the other one the shop owner will keep, and then if there's some sort of controversy, then the other samples can be tested as well. So that's basically the types of samples, right? Next, what can the MOH or PHI do if they find any violations at a food handling establishment?
So there's two things you can do. You can give them a warning or take them to the courts.
Yes, so I discussed this as well. So that's called issue a notice. That's the proper term. The warning is called a notice, right? You can issue a notice, and the other thing is they have legal action, right? The legal action at the courts, they will pay the fine. The PHI can't say give me 5,000 as a fine, nothing like that. They have to take legal action, and then the courts, they will have to pay they will say whether they are guilty or not. If they are not, say they are not guilty, they can challenge stuff like that. At the end, if they have to pay, they will pay, right? And the PHIs get a fraction of that. About 25% of that money will be given to the PHI. So that's sort of an incentive for them to do. In addition to that, they can also do seizing foods. Seize foods, and they can destroy foods as well, right? Right. So then some more cases of diarrhea were reported among customers of the same restaurant on the same day. So then what should be done by the MOH? You already gave the answer. This is a what? More cases are notified? Outbreak, right? So then same restaurant, many people who ate from the same restaurant are now getting sick with diarrhea. Now this is an outbreak situation. So then what should be done by the MOH? It's a outbreak response and management, right? So in this question, I didn't include I didn't expect all the details. If you just come out with the word, that would be enough, right? So outbreak management, there you have to inform the higher ups, the RDHS and everybody, and then you have to prepare a team and go within the golden hour to that restaurant or food handling establishment, collect samples, and then do something called line listing and stuff like that, where you collect information about the people who were affected, what are their symptoms, how long what is the duration from taking the food to onset of symptoms and stuff like that. And then you draw certain things. There's something called epicurve, the spot maps and stuff like that. And then you can decide which sort of you can use different study designs, case control studies, cohort studies, and you can use the statistical methods to decide which food item is responsible for this outbreak, right? So that is all in the outbreak management. So if you know that much, that would be enough. If you just come out with this term, that would have been more than enough. So this is what I expected here. So identifies food handling establishment, I gave separate marks because this is a term, right? Sorry. So in community medicine, you don't have many of these terms. But I want to emphasize is in these OSCEs, they will be very specifically concerned about terms, right? They will be waiting to hear certain very specific, scientific, academic terms. So you need to make sure you know these, right? If not in community medicine, at least take this principle for the other subjects as well. They will be expecting them. So make sure to tell those names and stuff, right? So next, any of these three would be okay: registration, inspection, food and water sampling, seizing foods, give notification, legal action, and education. Either of those three, if you gave, you got the answers. And then the types of food sampling: formal and informal, microbiology and chemical. Simple, right? And then what can they do if any violations? We also discussed that. And then outbreak management and describe the main steps, right? Right. So that is all the stations I have. Do you have any questions up to now? So just two important messages before I finish this up. Please be thorough on your theory. Don't forget your theory. Like I said, community medicine, this is always attached to some sort of thing, right? So don't forget your theory saying that it's only confirmed MCQ. There's nothing like that. The community medicine parts, any of them can come, right? With the cancer patient, the cancer management, the prevention parts can come. Food, they can come. Occupation, again, if you might get a disease and then you might have an occupational history part, right? So any of those things can come. Even for your other subjects, please be thorough on your theory. You need that. Second part, this is not OSCEs, Vivas, cases. These are not things you can do. You can get better at by you just reading books. You need to practice, right? So at least have somebody over, have a friend, somebody where you can at least do a role play with one another and practice these things, because you will need to have this at your fingertips, and at a spinal level you need to know this stuff. So those are the two messages. Please be thorough on your theory and practice as much as possible, as close to the expected actual situation as possible, right? So if there are no other questions, I think we can wind up for now, right? Right, then good night, everybody.
Thank you,
Thank you,
sir.
sir. Good night.
Nice.
Yes, sir. Good night.
Thank you.